And then we have put into our national audit program, not whether it was screened successfully and what the retinal stage was, but actually did the retinal screening occur on time? Because that's the most critical thing. It can be very difficult to get into a neonatal unit and to examine the eyes of a baby who's undergoing critical care, who's on a ventilator, who has other headgear on for other forms of ventilation. And of course, those are the ones who you really don't want to miss, because they are critical. We've also, I think, got a long way to understanding how we use oxygen, and actually it's made us much more aware of the risk of retinopathy, because actually to improve mortality and to reduce the risk of necrotizing enterocolitis, which is a systemic and quite catastrophic disease, we have to maintain levels of retinopathy that we'd hope to bring down.
So do you, as a neonatologist, ask ophthalmologists about their opinion when it comes to setting the right oxygen level?
We haven't asked ophthalmologists because we've done the trials ourselves, and I think it's actually quite sad that although the relationship with oxygen was recognized in the 1940s, it's only over the last 10 years that we've done the studies to refine the relationship a little bit further.
Yeah. I think that came across very well in your talk as well, how important the role of oxygen is.
Yeah.
And how important it is to keep it in the right area,
yeah,
where it doesn't harm the eye, but also doesn't harm the rest of the body.
Yeah.
How do you do it in Mexico, Professor Martinez?
In Mexico, it's complicated. We have, as any middle-income countries, really very good hospitals or really very bad hospitals. Really very good NICUs and really very bad NICUs. And this is a problem because we can see in the babies the ones that were in a very good NICU and in a very bad NICU. And in the very bad NICU, they have oxygen, like they just put the oxygen 100% concentration without measuring the oximetry, and we have really bad ROPs.
And do infants go back and forth between these different hospitals, or does one individual infant usually stay in one hospital?
It stays in one hospital. It has to do with the economic background of the family. So, and that's the same problem in any middle-income country, Latin America, Southeast Asia, or Western Europe. The ones that are able to pay for a better standard of care, they have less ROP. But the ones that cannot pay for that, we have a lot of babies that are going blind because of a poor oxygen management in the NICUs.
And does that difference also affect the treatment decision? How do you come to a treatment decision, not regarding whether you do treat or you don't treat, but the treatment modality? Who comes together when that decision is made, and what are the factors that influence your decision on whether to choose laser or anti-VEGF therapy?
It has to do with what they have available in that area. Some may have laser and they will perform laser, but some they won't. So the fact that they have a drug that is accessible and you can find it easily in the market, then it lowers the amount of blind babies.
How is it done in the UK? Who decides? What role does the parent also play in that decision?
Yeah. I mean, I think the problem we face is actually educating parents to the importance of recognized retinopathy, because if you're going to treat with an anti-VEGF agent, that infant has to come back for follow-up. And if the family are not able to bring them back or willing to bring the child back for follow-up, then it might be actually dangerous to use an anti-VEGF agent. So there is an educational aspect to this that is both the responsibilities of the ophthalmologist, because they have to impress on the families the importance of the disease process and the likely consequences of it going wrong, and also the importance of coming back to have that eye checked. And that can be quite challenging for families who have got to go to the expense of travelling
over months,
often into a centre over months. I mean, we move a lot of babies between units because we recognise that you get the best outcomes if the baby's initial intensive care is in a central unit. But of course, also we have a restricted number of centres that would provide the treatment for retinopathy, so we have experts there as well. So there's a lot of travelling, and parents need to have that sorted out.
I think that's really important to emphasize. It's not just the eye, it's the whole social factors, the family. One factor we should make sure does not affect the treatment decision, however, is availability of treatment. So whenever you as a unit or as a team of doctors present the option laser therapy versus anti-VEGF injections, you should be able to offer both at an equal quality in order to really be able to decide. And I think this is where it becomes important to really emphasize this treatment should be done at centers that know what they're doing and that have both treatment options available at the same quality, because otherwise you always have a tendency to shift into one direction or the other depending on what is available or what you can do best. And that should probably not be guiding your treatment decision.
That's right. And there's a danger if people move rapidly to use anti-VEGF agents that the expertise that's held locally in laser therapy actually diminishes. So one needs to be really very clear that these should be managed in specialized centers by doctors who have a high level of expertise.
Couldn't agree more. So next question, what are the next steps? Where do we go from here? What would you want to see next after we've seen these developments in anti-VEGF therapy?
One is the screening, to have access to a real screening program. Not every country has a real screening program. Having access to screening is a key point. Second, the really good communication with the neonatologist and that they call us to go and screen these babies to see how the systemic things are. And once you have that and the baby develops the disease, you have to have a good communication with the parents regarding the advantages and disadvantages of each treatment and what are you going to do and the factibility of making a real follow-up of the disease. They have to understand that this is a lifetime disease. Even though you cure it, it can have lifetime sequels, both laser or anti-angiogenics. So, and that you don't see it. If you have something in the lungs, maybe if the baby becomes blue or something, they will run to the hospital. But in the eyes, you can't see what is really happening unless it's really bad.
So we need a screening program that is in place before the disease really comes to the worst extent, but then we need a second screening phase after that that basically goes on for life to make sure that we limit the number of amblyopia from strabism or from refractive errors, that we pick up retinal changes that lead to late retinal detachment. So it's really a lifelong disease.
Exactly.
One factor I want to go back to your talk, Professor Marlow, was when you talked about prevention of ROP. Is that something that we will see in the near future, that we can prevent these stages of ROP?
Well, I mean, there is research going on at the moment looking at the hormonal environment of the baby is removed from, and then trying to reproduce that postnatally. Although we were very excited by this, the early results haven't shown us that, but we haven't given up on that yet, and I think that's really important. The other thing I think that neonatologists can do, which is why thinking of retinopathy is part and parcel of the early intensive care, even though you're not screening there for it, is that we should reduce the amount of respiratory disease amongst our client population. And we now have most, if not 95% of women who deliver sub 32 weeks get antenatal steroids in the UK currently. We also know that we're beginning now to use much less in the way of oxygen in the delivery room, which of course may set the whole thing off by producing hyperoxia, which we know is very dangerous for you.
Even if it's just for a very short time?
Even if it's just for a very short time. I'm sure, you know, over a longer period it accumulates risk, but actually even that short period of time is potentially dangerous. And the next thing is that we are beginning to understand that the cutting of the umbilical cord immediately after birth actually promotes respiratory disease if it's done too quickly. And so we're now beginning to look at delaying that until the circulation becomes stable. Logistically, it's very much more difficult to do, but actually in terms of the benefit for the child, it's huge. And so if we can reduce our dependence on that, and there are other aspects of trying to treat infection and prevent the lung disease going on, which leads and drives the need for oxygen, we should be able to reduce that risk considerably.
Well, thank you, Professor Martinez, Professor Marlow, for this discussion amongst the three of us. I would now like to open up the discussion to our audience and start our question and answer sessions with your questions.
Everyone, we would like to thank everyone again for joining us today. We would now like to take time and answer your questions that you have submitted via the Q&A screen. And while we do so, you can still continue submitting questions that we can pick up and discuss here on the line. So let us start with our first question, and this one is for you, Professor Martinez. How do you correctly identify retinal zones clinically?
Well, the easiest way is using a 28 diopters lens. In this lens, if you center the optic nerve in the image, you will find the defined area of the circle that is the radius from the optic nerve twice the distance to the periphery, and that involves the macula. So if you center the image in the optic nerve, this is the zone 1. Then zone 2 is the remaining area from the aura in the nasal part as a concentric center, as a concentric ring, and zone 3 is the residual temporal crescent of the retina that is anterior to zone 2. So the easiest way is with a lens, with a 28 diopter lens.
I think that's a very important question, because clinically it really does depend whether you see a zone 1 or zone 2 disease. It does change your treatment indication. Not if it's a stage 3+, but in other combinations it will trigger treatment if it's in zone 1, and it might not trigger treatment if it's in zone 2. So that distinction really is clinically very meaningful. Another very interesting clinical question, but from a very different angle, is maybe for you, Professor Marlow. One person on the line asks if there's any change in the screening and follow-up for the micropreemie babies that we see nowadays. Do you have any changes that you have already done or are in the process of doing in your screening and follow-up phases in the UK?
Yes, thanks very much. We've been looking very hard at making sure that we don't miss these babies, and we know that the disease tends to start a bit earlier, so we tend to start screening a couple of weeks earlier. And we've been very, very keen, because you can sometimes see disease progress very, very quickly. We're very keen to start using RetCams and taking retinal images and sharing those with our ophthalmologists means that they're needed on the neonatal unit actually much less frequently.
And how does it change your follow-up period? Is that just done during the initial screening phase or also during follow-ups?
Well, I think one of the things, and ophthalmologists will answer this better than me, is that this disease can come back and cause problems later on. And one of the classic things is that parents don't see the importance of coming to see yet another specialist to have their eyes checked. And that's something that worries us greatly. So we are very much switched on to reminding parents that the ophthalmic follow-up is really important, and that actually in some ways it's more important that they come to that than to come to some of the other follow-up appointments they have. And we're trying desperately to make sure that this happens. It can be very difficult because sometimes you're looked after in neonatal units which are a long way from home. You stay with them because you've got a lot of neonatal illnesses, you've got other things going on in your family at the time. And that's a real challenge to parents. But we must really work very hard to get the message through that screening and ongoing exposure for retinopathy is really important to this group.
Yeah, that is actually also one of the questions that are popping up here on the screen. Somebody called this the follow-up for life protocol. And I think that's really an important message to convey to the parents. If you have been diagnosed with ROP or even treated for ROP, follow-up does not stop a week or two or a month or two after treatment. We have to have a careful eye on these patients, especially when they were treated with anti-VEGF agents, because they have a risk of recurrence in the months after treatment. But even thereafter, these eyes tend to be difficult eyes, and it's basically a lifelong disease where we have to make sure we follow them up intensely in the first months after treatment, but then don't lose sight of these eyes over the coming years and decades even, because they are at risk of complications even in adult life. Maria, there's another interesting question here, maybe for you to comment on. How do you differentiate avascular versus ischemic retina clinically? I think this is a very difficult question to answer. So I'm happy to hand this over to you.
Thank you. Well, the first thing you have to search when you are looking at that retina that you don't see vessels is that if there are pathological new vessels growing. If there are pathological new vessels, it's an ischemic retina. It's a baby that is undergoing through a stage of the disease. When it is a vascular retina, it's just retina that the metabolic demands of the retina are already covered by the choriocapillaris. But if it is ischemic, you will find like a fire, new vessels, probably plus disease, and clinical features that led us to think that this is an active disease. And probably that's the main differentiation between the both of them.
Mm-hmm. Yeah, I think that is really important to be able to distinguish the two entities also after treatment. Now, we have talked about the screening period, we have talked about the follow-up period. I would now like to circle back to the treatment itself. And there's one question here on the Rainbow study that I covered during my presentation. And maybe I would like to comment on that one. The question is, why is the success rate in the laser arm so low in the Rainbow study compared to other data? And I think that's an important question, and I can't give you an exact answer, but my opinion here is that we have defined a very strict endpoint in the Rainbow trial with regards to what qualifies as treatment success. Treatment success is obviously, in all studies, the absence of active ROP. But on top of that, in order to qualify as a treatment success in Rainbow, the infant had to survive until the primary endpoint. So that's the first challenge. Every child that died before the primary endpoint was considered treatment failure, irrespective of the state of disease during the post-treatment phase. On top of that, eyes that qualified as treatment success could not have any unfavorable structural outcome. So any eye that had a macular dragging, macular fold, anything that could disturb visual acuity in the long run was considered an unfavorable structural outcome and therefore not a success rate. And I think that combined endpoint of surviving until the primary endpoint, having no active ROP, and on top of that having no signs of unfavorable structural outcome is quite a challenging endpoint to reach. And therefore the success rates are lower in the rainbow per se in all 3 treatment arms compared to other studies. That's not only true for the laser arm, it's also true for the anti-VEGF arms. If you, for example, compare the